So what about when the disease comes back and patients have either had BTK inhibitors as part of their initial treatment, or the disease came back and then they got a BTK inhibitor and the disease is progressing? What do we do then? So CAR T cell therapy has become an option that we often reach for. And CAR T means that we are taking patients' own T cells, own immune cells out of the blood in a process that's called pheresis. We then take those T cells and modify them we send them off to a company to put on their surface this, what we call a chimeric antigen receptor that recognizes this protein called CD19 on the surface of the tumor cells. So those cells are then manufactured. The patient gets low-dose chemotherapy. So when these cells are given back to a patient, they're not destroyed. And then we reinfuse those CAR T cells and they go into the body and home to where the lymphoma is and destroy the lymphoma. So this is something that's FDA approved and that we're using. I will say, however, it does have some significant toxicity. So this is a treatment that we don't use in our elderly and frail patients. We also have a lot of experience using CAR T cell therapy in other subtypes of lymphoma where it was approved before it was even tested in mantle cell. So what kind of toxicity are we talking about? People can get flu-like symptoms, fevers, fatigue, achiness, and sometimes low blood pressure or like a severe infection type picture. So very rarely people will need to go to an ICU for medications to support the blood pressure. And then patients can also get what's called neurologic toxicity, so confusion. Sometimes patients can look like they're having strokes. We put patients on anti-seizure medication. Fortunately, we know how to treat these toxicities with steroids, and the vast majority of patients then recover completely over time, but it can be quite an intensive process. And this is always done on an inpatient setting at a center where there's a lot of expertise giving CAR T cell treatment. But even more recently, we have this newer treatment called bispecific antibodies that is a similar concept to CAR T cell in that we give an antibody. Rituximab is an antibody, so it's a protein. And this protein, this bispecific antibody, on one side binds to the lymphoma cells or the mantle cell lymphoma, and on the other side, it binds to your own T cells. So instead of engineering and putting a protein on the surface of those tumor cells, we can take this, what we call off the shelf, and give it to patients, and it brings the T cells to the B cells and causes destruction of those cells. So we do have, there's a drug called glofitamab that we're now using in patients with relapsed mantle cell lymphoma, and this may be a more appropriate treatment for someone who may not be a good candidate for CAR T cell therapy. And more to come on this. There are a lot of trials ongoing trying to make combinations of treatments that will really be very effective in patients with relapsed mantle cell lymphoma. The last thing I did want to mention was allogeneic stem cell transplant. So this is very different from an autologous stem cell transplant. An autologous means you're using your own stem cells, and it's really just a way to give higher doses of chemotherapy. An allogeneic stem cell transplant means we're finding a donor, and the goal is to replace the recipient's immune system with a new immune system after giving some chemotherapy. And this new immune system, the goal of it is to recognize the lymphoma and destroy it. So we do allogeneic stem cell transplant rarely, but occasionally when we have a younger patient whose disease is aggressive and they've had these other prior treatments, we work very hard to get them into complete remission and then refer them to one of our colleagues who does allogeneic stem cell transplant. So in summary, mantle cell lymphoma, rare disease, affects men more than women, mostly older patients. And what we've learned recently is doing high-dose chemotherapy with autologous stem cell transplant does not improve outcomes in patients who are in remission without any evidence of detectable disease after their initial therapy. Adding these new drugs, these BTK inhibitors, particularly acalabrutinib and zanubrutinib, with intensive induction appears to improve what we call progression-free survival. So more people are in remission, and that's sort of where we're moving. If we look at giving standard chemotherapy like bendamustine and Rituxan and maintenance Rituxan to older patients, the outcomes look very similar to using novel drugs like ibrutinib plus rituximab. So that allows us to really pick the most appropriate option for the patient sitting in front of us. And I think that's the art of treating patients with mantle cell lymphoma. You really have to look at how is the disease behaving and who is the patient? What kind of treatment are they going to tolerate and what are their preferences? Do they want to have something that's more aggressive or do they want something that they may be able to get with their local oncologist? We know that adding these BTK inhibitors to bendamustine plus Rituxan keeps people in remission longer, but there's probably some added toxicity. And again, we don't know whether that's better than doing it sequentially. And for patients where the disease has come back after initial treatment, we have good options, including CAR T cell and bispecific antibodies. And there are a lot of newer drugs that are in clinical trials and hopefully will be available for our patients in the next few years.